Lesson 15, Airway Management. Although most of the care you provide will not require the use of breathing devices or airway adjuncts, in some situations they can be used effectively as part of your care. Breathing devices and airway adjuncts can assist with helping maintain an open airway, ventilating a patient, administering supplemental oxygen. In this lesson, you will learn the purpose and use of airway adjuncts, suctioning, and how to handle situations involving foreign body airway obstructions. Okay, here's a scenario that we will be discussing in person. As an emergency medical responder, you respond to a call at one of the docks for an unconscious adult who collapsed for no apparent reason. You size up the scene and notice that a middle-aged male is lying face up on the floor and not moving. The patient is unresponsive with no severe bleeding. He is not breathing but has a pulse. You discover that the patient's chest does not rise when you attempt ventilations. Okay? So here's a scenario that we will be discussing in person, okay? So hold your thoughts on this and think about this, and we will discuss in person. So here we have suctioning, okay? Sometimes injury or sudden illness results in foreign matter, such as mucus, fluids, or blood, collecting in a patient's airway. One method of clearing the airway is to roll the patient onto the side and sweep the mouth with a gloved finger. However, finger sweeps should only be performed on an unconscious patient and only when material is visible in the mouth. Another method of keeping the airway clear is to place an unresponsive patient who is breathing in a recovery position. But a more effective method is to suction the airway clear. Suctioning is the process of removing foreign matter from the upper airway by means of a mechanical or manual device. Suctioning is an important step when fluids or foreign matter are present or suspected, because the airway must be open and clear in order for the patient to breathe, for any CPR breathing barrier to be effective. Ensure that you always have a suction device at the patient's side when providing care, okay? So here we go again on the slides here. This is the process of removing foreign matter, such as mucus, fluid, or blood from a patient's airway. You have two types of suctioning devices. You have a mechanical device, electrically powered, manual device that's hand operated, no energy source. Require sterile suction catheters for both. Use appropriate size. Airflow of 40 liters per minute at the end of delivery tube, okay? And then a vacuum of 300 when clamped. Okay, right here we have airway adjuncts. The tongue is the most common cause of airway obstruction in an unconscious person. Keeping the tongue from blocking the air passage is a high priority. Mechanical airway adjuncts known as oral or esophageal airways, OPAs, and nasopharyngeal airways, NPAs, can help you accomplish this task. Airway adjuncts come in a variety of sizes. The curved design fits the natural contour of the mouth and throat. Once you have positioned the device, you can use a resuscitation mask or a bag valve mask to ventilate a non-breathing patient, okay? So, mechanical airway adjuncts include oral and nasal. OPAs keep the tongue, the most common cause of airway obstruction, away from the back of the throat. and OPAs are used only on unconscious patients with no gag reflex. Okay, now we have airway obstructions. Airway obstructions. You have two types of airway obstructions, anatomical and mechanical, okay? Anatomical obstruction occurs when an airway is blocked by anatomical structure, such as the tongue or swollen tissues of the mouth or throat. The tongue is a common cause of airway obstruction in an unconscious patient because the tongue relaxes when the body is deprived of oxygen, causing the tongue to rest on the back of the throat, blocking the flow of air to the lungs. Mechanical obstruction, also known as foreign body airway obstruction, occurs when foreign objects such as food or toys or fluids such as vomit block the airway. So here we have again on the slides, anatomical obstruction from the tongue, okay, swollen tissues of the mouth, tongue, or throat. And then you have mechanical obstruction from foreign objects such as food or toys, fluids such as vomit. So now we have foreign body airway obstruction, okay? Foreign body airway obstruction causes choking and commonly occurs because of poorly chewed food, eating too fast, or laughing, talking, running, or walking while eating. A conscious person who is clutching the throat is shown what is commonly called universal sign of choking. Now remember, the universal sign of choking is a conscious person clutching their throat, okay? Okay, a person with a mild FBAO or foreign body airway obstruction, remember FBAO is foreign body airway obstruction, or partial airway obstruction, can still move some air to and from the lungs, often while wheezing, as long as the person can cough forcefully. Encourage continued coughing, but do not provide first aid care for choking. Severe airway obstruction is apparent when a person cannot cough, speak, cry, or breathe and requires immediate action, okay? Conscious patient. Measures to relieve severe foreign body airway obstruction in a conscious patient. When caring for a choking adult, several skills, abdominal thrust, back blows, and chest thrust have been shown to be effective at clearing an obstruction. Generally, EMR should provide abdominal thrust to attempt to clear an obstruction, but they may perform a combination of skills such as back blows followed by abdominal thrust based on local protocols. Each abdominal thrust, back blow, or chest thrust should be a distinct attempt to dislodge the object. Using more than one technique is often necessary to dislodge an object and clear a patient's airway. Continue performing abdominal thrusts or a combination of skills until the object is dislodged and the patient can cough forcefully, speak to breathe until the patient becomes unconscious, okay? Abdominal thrust may not be an effective method for choking adults in cases where you cannot reach far enough around the patient to give effective abdominal thrust, or if the patient is obviously pregnant or known to be pregnant, okay? Now we're going to deal with unconscious. If a patient who is choking becomes unconscious, Carefully lower the patient to a firm, flat surface while protecting their head. Send someone to get an AED and summon additional resources if appropriate, and you have not already done so. Immediately begin CPR, starting with chest compressions, okay? And as you open the airway to give ventilation, look in the patient's mouth for any visual objects. And this is where the finger sweep, if object is visible in the mouth. Okay, next here we have a scenario, and this is in person. You guys know all of our scenarios are in person. While attending a picnic, you notice that a 4-year-old boy begins coughing very forcibly while eating a hot dog. His mother appears frantic and begins shouting for help. As a trained EMR, you respond to the mother's call for help. So look at the scenario here. This is another in-person scenario. Okay, put this on the shelf and think about how you will respond to this. Okay, we have another scenario here. Okay, you are the emergency medical responder. You reposition the patient's airway and attempt another ventilation, but the chest still does not rise. Okay. After a few minutes of care, the patient's chest begins to rise and fall with the ventilations, but he is not breathing on his own. Okay. What steps would you take next in this scenario? So here's another in-person scenario. So go ahead and put it on the shelf until we can meet in person. Okay. Nasal airway enrichment. When properly positioned, the nasal airway keeps the tongue out of the back of the throat, okay, thereby keeping the airway open. An NPA may be used on a conscious, responsive patient or an unconscious patient. Unlike an oral airway, the NPA does not cause the patient to gag. NPAs must not be used on a patient with suspected head trauma or a suspected skull fracture. When using an NPA, select the proper size. Measure the device on the patient to see that it extends from the angle of the jaw to the tip of the nose. Also, make sure the diameter of the NPA is not larger than the internal diameter of the nostril. To insert the NPA, lubricate the airway and the opening of the nostril with a water-soluble lubricant. Insert the NPA into the right nostril with the bevel toward the septum, the wall of the tissue that separates the nostrils. Advance the NPA gently, straight in, not upward, until the flagella rests on the nostril. If you feel even minor resistance, do not force the NPA. If you cannot get the NPA to pass easily, remove it and try another nostril. If you use the left nostril, you need to ensure that the bevel is inserted towards the septum and the NPA is rotated as you advance in it, similar to the OPA, okay? So we have here use for a conscious nasal airway, used for a conscious responsive patient, okay? Patient who is unconscious. Contradictions for use are suspected head trauma, as we discussed, suspected skull fracture. Lubricate the airway and the opening of the nostril with a water-soluble lubricant. And we're going to insert the airway into the right nostril with the bevel towards the septum. Okay, so that concludes Unit 15, Lesson 15.